Exploring rational and irrational behaviors, indirect acceptance in peer mental health, and Rena's story of smoking, suppression, and systemic betrayal. By Nisa Pasha, executive political health guru, peer counselor, and educator. mentalhealthrevival.org. Mental health is not only a matter of clinical diagnoses, therapy sessions, and medication adherence, it is deeply intertwined with personal autonomy, lived experience, and the subtle forces of acceptance and neglect within behavioral and health systems. For many pure mental health consumers, navigating the mental health system can feel like walking a tightrope between support and neglect, autonomy and regulation, acceptance and betrayal. This story explores the lived experience of Rena, a pure mental health consumer who struggled with indirect acceptance from social workers, case managers, and the broader mental health system, specifically around smoking cigarettes during day treatment and at home. Her experience illuminates the emotional and psychological impact of tolerance without guidance, the feelings of suppression and harm, and the ways in which peer advocacy and empowerment can foster healing. Rena's perspective, the environment and the context. Rena was diagnosed with a mood disorder in her early 20s. She attended a day treatment program designed to provide structure, therapy, and rehabilitation in a supportive environment. She was grateful for the mental health services available, but she often felt a conflict between her own health needs and the indirect messages she received from social workers and case managers. One of the most striking examples was the system's tolerance of smoking cigarettes. Smoking was technically discouraged but rarely enforced, and peer clients were often left to their own devices. Rena noticed that social workers and case managers rarely intervened when clients smoked indoors or on the premises. Warnings about health risks or medication interactions were inconsistent or superficial. Smoking became normalized as a coping mechanism, with staff indirectly signaling it was acceptable to smoke, as long as behavior was not overtly disruptive. For Rena, this indirect acceptance created a sense of betrayal. On one hand, she trusted the mental health system to prioritize safety, well-being, and holistic health. On the other, she saw peers being exposed to preventable harm and toxic behaviors, sometimes reinforced by the very individuals tasked with guiding recovery. Emotions, thoughts, and psychological impact. The experience of indirect acceptance triggered a complex array of emotions for Rena. Frustration. I felt angry that the people I relied on for guidance allowed behaviors that I knew were harmful. It wasn't rebellion, it was harm prevention, and they were ignoring it. Confusion. If smoking is dangerous, why do the staff let it happen? Are they responsible for our health or not? Helplessness. I wanted to intervene, speak up, or advocate for my peers, but I feared retaliation or being labeled as difficult. Guilt and self-doubt. I questioned my own choices. If I didn't smoke, was I the odd one out? Was I failing to cope like everyone else? Resentment and betrayal. The system's tacit tolerance felt like a subtle sanctioning of harm, creating a paradoxical environment where Rena's desire for health and autonomy clashed with normalized destructive behavior. Psychological mechanisms at play. Indirect acceptance in this context had profound psychological consequences. Internalization of harm. Rena absorbed the system's tolerance as an implicit message that harm was acceptable, leading to stress and ambivalence. Suppression of emotional agency. Her anger and concern were suppressed, creating cognitive dissonance. She wanted to act, but felt powerless. Normalization of risk. Repeated exposure to peers smoking without intervention desensitized Rena to the dangers. Immediate health warnings, affecting her vigilance regarding medication side effects and dietary health. Identity confusion. Her sense of self as a health-conscious, accountable peer was undermined by the discrepancy between her values and the system's practices. Bullet summary. Emotional impact for Rena. Anger suppressed by social and institutional norms. Anxiety over peer safety and personal accountability. Distrust toward behavioral and mental health systems. Emotional exhaustion from moral and ethical conflict. Low sense of autonomy and agency. The role of social workers and case managers. Social workers and case managers play a critical role in guiding behavior, maintaining safety, and providing education. In Rena's case, indirect acceptance manifested in several ways. Non-intervention as implicit approval. Staff often overlooked smoking during day programs. By failing to enforce rules consistently, they indirectly communicated that the behavior was acceptable. Minimal health education or counseling. Limited discussion of smoking-related respiratory, cardiovascular, or medication interaction risks. Absence of personalized harm reduction strategies for each peer. Systemic barriers. Staffing shortages or program policy constraints limited active monitoring or intervention. Peer autonomy was overemphasized in ways that enabled risk behaviors. Indirect psychological effects, responsible for their own safety, and unsupported by the system. A sense of betrayal emerged when the system failed to act proactively, fostering mistrust. Peer insight. From a peer perspective, indirect acceptance by staff can feel like passive endorsement of harm, especially when peers rely on guidance and advocacy for safety and wellness. Daily life experiences, smoking, medications, and dietary conflicts. Rena's lived experience extended beyond the program into her home and social environment. Smoking as a coping mechanism. Rena observed peers using cigarettes to suppress anger, stress, and anxiety. Medication interactions. Nicotine altered medication efficacy, but indirect acceptance by staff meant warning signs were underplayed or ignored. Dietary conflicts. Peer education on nutrition, including whole grains and fiber, often clashed with smoking-induced digestive issues, leading to incomplete elimination, toxic retention, and recurrent discomfort. The combination of dietary suppression, behavioral acceptance of smoking, and system tolerance created cyclical depletion. Cigarettes suppressed immediate emotional stress, but worsened physical health. Digestive disruption from high-fiber foods compounded internal discomfort. Lack of guidance or intervention normalized this depletion, preventing Rena from fully advocating for herself or others. Bullet summary. Health interactions. Smoking plus medication. Altered efficacy. Side effects overlooked. LI. Dietary patterns plus smoking. Incomplete elimination. Gastrointestinal stress. PLI. System tolerance. Normalization of harm. Lowered vigilance. PLI. Peer suppression. Internalized stress. Cognitive dissonance. PLI. #2 Feelings of betrayal and psychological harm. #2. Rena's experience reflects the emotional weight of systemic betrayal. PLI. Loss of trust. Strong line. The system she relied on appeared complicit through inaction. PLI. Isolation. Feeling that concerns were unheeded or dismissed reinforced peer marginalization. PLI. Anger suppression. Repressing anger led to strong internalized tension and psychological strain. PLI. Emotional fatigue. Maintaining alertness while witnessing harm drained mental energy. Moral conflict. Peers observed behaviors they knew to be harmful, but were powerful to change systemic acceptance. Peer-centered reflection. Rena internalized both the harmful behaviors and the failure of her support system, demonstrating the profound psychological cost of indirect acceptance in mental health systems. What can be done for peer consumers like Rena? Intervention strategies should address autonomy, empowerment, education, and systemic accountability. Peer empowerment. Encourage self-advocacy and shared decision-making. Provide tools for observing internal cues and recognizing harmful tolerance patterns. Build peer circles for mutual accountability and support. Systemic accountability. Staff training on active harm reduction and emotional support. Policies that balance peer autonomy with health and safety oversight. Transparent discussions of health risks, dietary impacts, and medication interactions. Behavioral alternatives. Introduce non-nicotine coping strategies. Mindfulness, journaling, movement, breathing exercises. Provide educational materials on dietary and behavioral health interactions. Encourage gradual behavior modification instead of abrupt cessation, respecting peer autonomy. Emotional validation. Recognize and validate anger, frustration, and distrust as legitimate responses. Normalize the complex emotions associated with indirect acceptance and systemic failures. Facilitate reflective exercises for peers to articulate feelings and process betrayal. Bullet summary. Peer support interventions. peer-led workshops on harm reduction, journaling prompts for emotional processing, small group discussions on autonomy and decision-making, educational modules linking diet, behavior, and mental health, supportive check-ins with trained peer mentors, inspirational insights and healing strategies. Despite the challenges Rena faced, her story also reflects resilience and potential for growth. 1. Healing through awareness. Recognizing indirect acceptance patterns is the first step to reclaiming autonomy. 2. Empowerment through peer support. Connecting with peers who share similar experiences fosters mutual encouragement and accountability. 3. Transforming betrayal into motivation. Experiences of neglect or systemic tolerance can inspire advocacy, community engagement, and self-care practices. 4. Mindful behavioral change. Incremental steps, whether quitting smoking, adjusting diet, or improving medication adherence, allow peers to regain control over health outcomes. 5. Educational outreach. Sharing lived experiences with staff, peers, and community programs contributes to systemic change and improved support. Structures. Pause. Conclusion: turning indirect acceptance into awareness and growth. Rena's experience illustrates the complex interplay between behavioral health, dietary patterns, systemic tolerance, and peer mental health. Indirect acceptance, while sometimes adaptive, can exacerbate harm when coupled with risky behaviors or systemic inaction. Key lessons from mental health awareness. Indirect acceptance is not neutral. It carries emotional, cognitive, and physical consequences. Peer empowerment and lived experience are critical for reclaiming autonomy. Systemic accountability, education, and harm reduction strategies can transform tolerance into informed guidance. Emotional validation, peer support, and mindful behavioral strategies promote resilience and regenerative capacity. Healing is iterative, community-driven, and rooted in awareness and self-compassion.